and welcome back to EASD TV. Vivian Parry here. I'm delighted to have with me people who've been speaking at a very intriguing session called Why Does Diabetes Make One So Sad? And with me I have a diabetologist, a psychologist, and a new one for us at EASD TV, a market researcher. So let me introduce each of them to you. So first of all, the diabetologist that I promised, Ningijan Wang from the University of Shanghai. We have Seohyun Kun, who's a psychologist from, and I hope I get this right, Seohyun University in South Korea.
That's great.
Wow. And finally, Evelyn Cox, market researcher from San Francisco. So let me start with you, Ningijan.
Mm-hmm. Okay.
What is the general perception of depression and mood problems in people living with diabetes amongst diabetologists?
Well, in fact, diabetes, as we know, has been a pandemic globally, and it brings complex complications and great social and healthcare burden. And China will still have the biggest population of diabetes in 2045. The diabetologist in China has a great burden. Okay, but depression or broad depression in my study is also a chronic medical illness. It could be characterized by low mood, insomnia, sadness, and inability to enjoy life. And according to data, since 10 years ago, depression has already accounted for the biggest share of disease burden measured by years lost to disability. So we are considering whether these two conditions, chronic illness, are connected. And of course, there are some studies that has found that depressed people have increased the risk of type 2 diabetes.
So you're talking about not depression as a consequence of diabetes, but depression as a cause of diabetes,
yes.
Which is a very intriguing thought. But depression, as far as I can see, has been rather low on the list of diabetologists' concerns. They're more worried about other complications, the cardiovascular disease, the neuropathies and things like that.
Yes, that's why we do this study and want to advocate the importance of caring about patients' mood in our clinical work. That's what we are doing. And I have mentioned that the depression has already accounted for the biggest share of disease burden, more than CVD and more than cancer, more than diabetes. So it's very important.
So why do you think depression has been ignored?
Why? So I think this is a really complicated question. Maybe diabetologists think they are not work. It's hard to deal with someone who has mood problems. Maybe this is the psychological doctor's work. I think so. Maybe they do not know. Maybe I think the doctors, the diabetologist may not be good at dealing with these problems, I think.
So Seohyun, you're nodding there. You obviously agree diabetologists don't really interest themselves in depression. But tell me a little bit about your work.
In our population-based study, the risk of mental disorders and depression in adults with new onset type 1 diabetes is about 2 times and 3 times compared to general population without diabetes. So we found that the type 1 diabetes is actually very physically and psychologically demanding disease, and compared to the other chronic disease, type 1 diabetes has to inject insulin. It is external behavior. So I think the association between type 1 diabetes and depression could be explained by cognitive behavior model.
So Evelyn, you've done a lot of research in this area. Is that your finding too?
That is our finding. Throughout the longitudinal studies that we do at DQ&A, which is my market research firm based in San Francisco, we also find that anxiety and depression have a 29% prevalence, which is 5 times what I'm seeing for the global prevalence of anxiety and depression among general population. So we see that the burden of these diseases is incredibly high, and that also a lot of our work has gone into capturing that cognitive burden. We have adapted some of the findings from the DDS scale, the diabetes distress scale, to calculate a new measure, trying to capture the experience of people with diabetes and the emotional burden that is associated with it. And we see incredibly high rates of that burden, suggesting that, yes, that the emotional factor surrounding diabetes is a major experience that people with diabetes have, and definitely needs to be considered more when treating patients.
So for the average diabetologist, what does your work tell you will be helpful to patients?
Yes, so the research we are presenting at this conference suggests that there are several mental health coping and management strategies that do have an association with positive or improved diabetes health outcomes, such as hemoglobin A1C and time in range. Some of these strategies include relying on psychotherapy, talk therapy, exercise, relying on your social support networks, as sort of predictors for more positive mental health and diabetes health outcomes, whereas something like psychiatric medication use actually has an association with decreased time in range and increased A1C. So I do think that there is some work to be done on the behalf of diabetologists towards shifting and both informing patients of the work that they can be doing to improve all aspects of their care, and also guiding them towards strategies and solutions that would work best for them and then for their context.
So what I'm hearing from you is that there are some really clear red flags that diabetologists ought to be aware of that indicate that this particular patient might have need of greater support with their mental health.
Definitely.
Seohyun, what would you suggest from your work? What would you suggest diabetologists do for their patients?
First of all, when patients have type 1 diabetes in adulthood, clinicians focused on the mental problem among them. And in our work, we also found between age 40 and 50, the relative risk of having incident mental disorder is higher than other ages group. So clinicians have to focus on the adults with type 1 diabetes occurs between age 40 and 50.
Fascinating. Let me come back to you. Mm-hmm. Does this say to the diabetologists who are watching that it's very, very important to consider depression and other mental health problems?
Yes.
As a very important consequence? I mean, we're talking, I know you talked about it as being a cause, but
yes,
a consequence of diabetes that people ought to pay as much attention to as neuropathy or cardiovascular or, retinopathies.
Yes, it may. Our study has several clinical or scientific implications. The first, we think depressed patients should be screened for type 2 diabetes to reduce the risk of type 2 diabetes. Maybe every 1 year to screen the type 2 diabetes in depressed patients. And second, our study found 11 circulating metabolites mediate the association between depression and incident type 2 diabetes. So by understanding the causal relationship between depression and incident type and metabolic dysfunction, we can use targeted interventions to stop the metabolic disturbance in patients with broad depression, may curb the risk of type 2 diabetes in such patients. So that's what we found. I talk a little. So.
Thank you. Well, thank you so much, all of you. What I've taken away from this is, first of all, the need to screen people with depression for diabetes,
Yes.
but also once people have diabetes, it's very important to pay serious attention to their mental health problems. And actually, those mental health problems may have a really serious impact on their HbA1c as also their time in range. So, yeah, depression is important. Really think about it in your patients. There's much more to come from EASD TV. Bye for now.